Hi, very good morning. I'm Dr. Janak Patel, MD, General Physician. All my video lectures are for educative purpose. This lecture will be also very useful to fourth year student, interns, and the person who goes for a private practice. Because every now and then you will be looking at the ECG and you are always worried about a Q wave. So today we'll be discussing on one of the another part in our ECG series we call as a Q wave, whether it is benign or pathological. Pathological means there is some damage to the myocardium and that is producing Q wave. So we'll be dealing with that particular aspect of Q wave. So we'll be dealing with pathological Q wave and normal Q wave. So whenever you see a Q wave, you should be able to differentiate whether it is due to damage to a myocardium or it is a normal Q wave because of the septal activity. So we'll be discussing on pathological Q wave and non-pathological Q wave, and then whatever is the treatment possible depending upon the etiology. So we know very well that normal QRS complex first negative wave is Q, first positive wave is R, second negative wave is called S. And we'll be talking mainly in detail regarding what is a Q wave. So this is normal, you can see that this is normal Q wave, R, there is no S wave here, clear? While here you can see a R wave and this second negative wave after first positive is called as S wave. So first negative is Q and second negative is called S wave. Here also you can see a small Q wave. Here also there is a small Q wave. So you can see a Q wave in good number of leads. We'll be talking about what is normal. So first negative is Q. If both are negative, there is no positive wave at all, then by and large the word utilized is QS. And if you get a first negative and second negative, so first is called Q and second negative after a positive is called S wave. And if you get a big deep Q wave and there is a small positive wave, so we write down capital Q and second R wave we write down in a small alphabet. So this is a terminology which is being utilized in a QRS complexes. So rule number 9, that there should be no Q wave or only small Q wave less than 0.04 second, means as far as duration is concerned. As far as depth is concerned, 1 small square. In lead 1, lead 2 and V2 to V6. So normally even if you get the Q wave, it is not broad and it is not deep. So you can have a Q wave in lead 2, lead 3, AVF, but there is no Q wave in lead 1 and AVF. This is normal frontal loop. So here you can see that in lead 1 and AVL there is no Q wave. But by and large we always say that Q wave is because of initial deflection that precedes the R wave, and this is because of a septal getting activated from left to right. So as the septum is getting activated from left to right, you will see a Q wave, you will see a small Q wave. This Q wave will be seen more commonly in a what we call as a inferior and lateral leads. So you will be able to see this Q wave very nicely in lead 2, lead 3 AVF, lead 1 AVL and V4, V5, V6. Indirectly, Q wave is not seen commonly in lead V1, V2 and V3. in these three leads, usually we don't see a Q wave. So small Q waves are normal in all the leads except what we call as V1, V2 and V3. By and large, V4, V5, V6 may show a small Q wave because of septal activity. So normal Q wave is found in lead 1, AVL and V5, V6. They are usually width-wise less than 1 small square, depth-wise maximum is 2 small square. So that is normal. But if you find Q wave in any lead which is more than 1 small square in width, means more than 0.04 second, or more than 2 small square in depth, or more than 25% of the R wave which is following a Q wave, and this should be at least in 2 consecutive leads or 2 successive leads or 2 contiguous leads, then it is pathological. Then we consider that as pathological. So this criteria is very important. Duration more than 0.04 second, depth more than 2 small square, or 25% of the following R wave, and minimum in 2 successive lead or consecutive lead or contiguous leads. So some people also says that more than 30 milliseconds in duration. If it is present in V1, V2, V3, it is always abnormal. So if you see in V1, V2, V3, it is considered as abnormal. We also label them as a QS pattern in V1, V2. If you get this QS pattern in V1, V2, it is always pathological. And depth more than 25% of R wave height, that is also pathological. Or we say that more than 2 small square in depth. These are standard criteria. So Q wave more than 2 small square in depth, more than 1 small square in width, and height if you consider and compare with the R wave, more than 25% of the height of following R wave is considered as a pathological Q wave. And this Q wave you will get in acute MI or a healed MI or even in a healing MI. Hypertrophic obstructive cardiomyopathy, or we call as IHSS, also in case of a dilated cardiomyopathy. So Q wave is more than 25% of R wave. You can have also in a non-pathological condition like lead placement error, particularly if there is an inversion of upper arm, right arm and left arm between 2 arms. You will have a Q wave in lead 2, lead 3 and AVF. So normal Q wave is 1 small square in duration and 1 small square in height, but in a depth not more than 2 small square. If it is present in 2 contiguous leads and if it is more than 0.04 second in duration and in a depth wise more than 2 small square, or more than 25% of the height of R wave, it is considered as pathological. And if there is a presence of QS pattern in V1, V2, V3 or even in V1, V2, it is abnormal. Lead 3 and AVR can have a large Q wave. This is again because of a septal activation. So this criteria should be kept in mind. So normally you get in lead 1, lead 2, lead 3, AVL and V5, V6. This is a common where you can have a small Q wave which is maximum 0.04 second in duration and 1 or 2 small square in depth. But more than that, it is always abnormal. So now you can see here there is a Q wave which is because of the septal activity. So if you come across a deep Q wave, it is always abnormal. So septal Q wave in lead 1 is a small amplitude, but if you get a deeper one, it is abnormal. So in 2018 and later on in 2019 also, there was a criteria which was being laid down for Q wave, that ECG changes associated with prior MI in absence of LVH and LBBB. What were the criteria? Any Q wave in lead V2, V3 which is more than 20 millisecond, that is duration wise, that is we call more than 0.2 second, or QS complex in lead V2, V3. So you get only negative wave, that is we call QS in V2, V3. It is always considered as abnormal and we label that as anteroseptal MI. If Q wave is more than 30 millisecond and 1 millimeter depth or QS complex in any two contiguous leads, either in lead 1 AVL or V1 to V6 or lead 2, lead 3 AVF, it is considered as abnormal. And if R wave is more than 40 millisecond in V1, V2, and if R to S ratio is more than 1, meaning the R wave is taller than S wave, and there is a concordant positive T wave in absence of conduction defect, it is again considered as abnormal. This is very important because if you come across an R wave which is prominent in V1, V2 or even V3, and R wave is bigger than S wave, and if you got a ST segment depression, it is in favor of a true posterior wall MI. This should be kept in mind. So pathological Q wave is diagnostic of myocardial infarction in presence of ST segment elevation. But if there is no ST segment elevation, ST segment is isoelectric and T wave is upright, and if the Q wave is significant, meaning it is more than 0.04 second in duration, and depth wise we have already mentioned more than 2 small square or more than 3 small square, and more than 25% of the successful R wave, then it is in favor of what we call as a pathological. And pathological meaning if it is in the presence of ST segment elevation, it is acute MI, and if it is ST segment is isoelectric and T wave is upright, we usually label that as an old infarct or healed infarct. So if there is a new Q wave, it suggests myocardial necrosis which starts within few hours after acute MI. So anytime you get a Q wave which is significant enough, always consider that pathological Q wave is either a current MI or an old MI. So you have to consider that. And also the absence of a small septal Q wave in lead V5 and V6 should be considered abnormal, because absent Q wave in V5, V6 is usually due to left bundle branch block. So that should be also kept in mind. So left bundle branch block, Q wave will be absent in V5, V6. So whenever you want to evaluate only isolated Q wave, you must have a good history, good physical examination, have a good family history, ask in detail, and you should look for coronary risk factors like smoking, hyperlipidemia, obesity, cardiometabolic syndromes, etc. And you should evaluate by ECG, echo, and if required even angiography to differentiate MI, dilated cardiomyopathy, and hypertrophic cardiomyopathy. Also sometimes you might require stress testing to rule out ischemia depending upon the clinical presentation. Cardiac MI for scar assessment if echo is not giving you a good answer, or we use the word if echo is ambiguous and you want to also evaluate for the person who is an athlete. So you want to evaluate athlete's heart, you must look for presence of Q wave. It is important. Now if we go through this is a very good chart that Q wave, if it is present in two contiguous leads, or you get a QS segment in V2, V3, and if it is pathological, always think in terms of a subsequent pathology like acute MI or old MI. So presence of a Q wave MI, or we call STEMI, that will be acute if there is an ST segment elevation simultaneously, and if there is no ST segment elevation, it is isoelectric and T wave is upright, we will label that as a old MI. But in case of a LBBB, LAHB, LPHB or LAFB, left anterior fascicular block, left posterior fascicular block, pulmonary embolism, you get a infiltrative disease of a myocardium, WPW syndrome, myocarditis, injury to the myocardium, chest wall deformities, and lead reversal, where you get a presence of a Q wave, but it does not signify damage to the myocardium because of coronary artery occlusion. That's why it is also labeled as a pseudo-infarct. This should be identified, because if it is wrongly identified, the patient will be treated as an acute MI, and you can end up with a complication of a treatment complications. And opposite of that, if person is already having an acute MI and we don't pick up those cases and we don't treat them, you can end up with a permanent damage to the myocardium, and that will be permanent Q wave appearance. So always look for that, and depending upon where you get a Q wave in left bundle branch block, it is mentioned very clearly, you will get in V1, V2 and V3, and also you might see a Q wave in lead 3 and AVF, in left anterior hemi block in lead 1 and AVL, and in left posterior hemi block lead 2, lead 3 and AVF, we call inferior leads. Pulmonary embolism, mainly you will see a Q wave in lead 3, we call S1, Q3, T3 pattern. In infiltrative disease again, it will be again in V1, V2, V3, like in case of a left bundle branch block. In a case of a Wolff-Parkinson-White syndrome, you will usually have Q wave because of negative delta waves, depending upon the type of a Wolff-Parkinson-White syndrome. Myocarditis may produce a Q wave depending upon the area of involvement. It can be in a multiple leads. In a even myocardial damage also, myocardial contusion, it will be in a multiple leads depending upon the area involved. In a chest wall deformity also same. In a lead reversal, mainly you will see a Q wave in lead 2, lead 3 and AVF. In case of a lead reversal, it will be more common, and in a lead reversal, in a AVR, you will get a R wave, upright QRS complex. So do remember this. These are all, we can say that they are pseudo-infarct. They indicate some pathology, but these are non-ischemic. So always we want to rule out ischemic versus non-ischemic group as far as looking at the Q wave. But all those are put into a common word called pathology Q wave. So these are non-ischemic pathological Q wave. This is ischemic pathological Q wave. So even hypertrophic obstructive cardiomyopathy can also produce appearance of a Q wave, particularly in lead 1, AVL and V5, V6, quite common. So you can have a Q wave in myocardial infarction. Recognized and unrecognized means STEMI and non-STEMI. WPW syndrome, myocarditis, dilated cardiomyopathy, hypertrophic cardiomyopathy, infiltrative myocardial involvement like Chagas, sarcoidosis, amyloidosis, etc., and lid placement issue. So in all these conditions, you can have a Q wave appearance. The depth may be little more, but width and depth both will be affected in case of myocardial infarction. So do look for that. Rule out ischemic from all these are other non-ischemic groups. These are non-ischemic groups. So that should be ruled out because those will not be having a high mortality except in a case of a myocarditis, dilated cardiomyopathy and hypertrophic cardiomyopathy where you can have a mortality. So myocardial infarction comes topmost on the list to be ruled out. Second is hypertrophic cardiomyopathy or infiltrative myocardial disease like sarcoidosis, amyloidosis, Chagas, etc. You can have also Q wave in an extreme clockwise or counterclockwise rotation, and lid placement error will be coming across. This is definitely pathological, depth-wise and width-wise also. This is also depth-wise and width-wise clinically significant. So definitely this is pathological. So as far as myocardial infarction is concerned, we label that as an acute MI or healed MI or old MI. We already mentioned all this. There is one condition we call as a non-Q wave subendocardial infarct where you don't have a Q wave, you got an ST depression, but if not treated, you can have a Q wave appearance because subendocardial infarct can proceed to a complete transmural infarct and then you can have a Q wave and you may not have an ST segment elevation. So you should pay attention to this and try to also identify subendocardial infarct, and if the person who has got these changes in an ECG where there is no Q wave, there is ST depression, there is elevation of troponin, person is having a persistent chest pain, do treat that as an acute MI and that we call as a non-STEMI. So that should be treated as that. So do look for that condition. You can see here there is a Q wave, ST elevation and T wave is inverted. This is 100% acute MI. This is a Q wave, ST segment is still elevated. This is again acute MI. So there may be a small Q wave, but when there is ST segment elevation with a small Q wave and then the depth of Q wave starts becoming more and more, this favors acute MI. You can see that the depth is becoming more, then ST segment will become isoelectric, and when it becomes upright, this is healed, this is acute. This all favors acute. So always look for those signs. So when you get the only Q wave with ST segment isoelectric and T wave has become upright, that will suggest healed infarct, and this should be present in minimum 2 contiguous leads, or we call 2 subsequent leads, whatever word you want to utilize. So pathological, these are also all pathological, this is also pathological, and if they are present in a 2 contiguous leads, it is 100% in favor of ischemic heart disease. Depending upon the ST segment, you can label that as an acute or you can label that as a healed infarct. So we have already mentioned those particular criteria, and whenever you want to look for Q wave, use depth ratio criteria, that is ratio to R wave, width criteria, that is 0.04 second, number of leads being involved and location, very important, 2 consecutive leads or 2 contiguous leads. So commonly what is being utilized, more than 0.4 second as far as duration is concerned. As far as ratio is concerned, R to S ratio is more than 25%, and depth more than 3 small square, straightforward in favor of pathological Q wave. Now you can see here, this is a lid where you can see in lid 2, lid 3, AVF. Lid 2 there is a small, in lid 3 there is a little deeper one, in lid AVF also there is a deeper one. Q wave is present. More than 2 consecutive lids. ST segment elevation, straightforward acute inferior wall MI. Again you can see here, inferior wall MI, right? While here, you can see there is a QS pattern in V1, V2, V3. So straightforward this is involving anterior wall. So it is extending with ST segment elevation. So right from V1 till, from V1 till almost V5. So this is involving good number of lids. So V1 to V5, it will be anterior wall, acute anterior wall. So do look for that. V1 to V4 though definitely clear. Even in V5 there is a little amount of ST segment sagging up. Now here you can see that clear cut Q wave, significant, pathological, and there is an ST segment elevation with T wave inversion. This is acute MI. But if you come across no Q wave but ST segment depression and person has got persistent chest pain, do suspect non-STEMI. And even if there is an T wave inversion, do keep it in mind, it can be T wave inversion also in case of a non-STEMI. And have a subsequent leads, subsequent ECGs. So in a transmural you will get an ST elevation, but in a non-transmural you can get an ST depression or symmetrical deep inversion T wave. We call as a subendocardial infarct or non-STEMI. So do look for that. Here you can see that deep Q wave in lid 3 and AVF, and there is an ST segment elevation. This is straightforward in favor of inferior wall MI. Again, deep Q wave with ST elevation in lid 2, lid 3 and AVF, inferior wall MI. Here again you can see there is a Q wave in lid 2, lid 3 and AVF, but ST segment is isoelectric, T wave is upright. So this will go for old inferior wall MI. While here you can see a QS pattern with ST segment elevation, T wave is inverted in V1, V2, V3. QS pattern in V1, V2, V3, anteroseptal. And you can see also T wave inversion in V4, V5. So this is definitely in favor of anteroseptal MI. Again, in A, you can see in lid 1, AVL, V2, means it is from V2 to V6, there is an ST elevation. And in V2 you can see a QS pattern. QS pattern. This is acute MI. Now there is a QS pattern, ST segment is isoelectric, T wave is still inverted. And here it has come to isoelectric line. So this is healing. And when you get QS pattern, ST segment isoelectric, T wave is upright. Now this is healed. So this is acute, this is healing, this is healed one. So you can see here in lid 1 and AVL, Q is persistent, ST segment is isoelectric, T wave is upright. V1, V2, V3, even in V4, there is a QS pattern with ST segment elevation. This will be acute anteroseptal MI. Clear? While here, if you look at this particular, there is a R wave and then there is a S wave. R wave and this is a S wave. This is not Q wave. So this is not inferior wall. This is anteroseptal MI. In a posterior wall MI, in V1, V2, V3, you will have a R wave prominent more than S wave. You will have a ST segment depression with the upright T wave. It will be straightforward in favor of a posterior wall MI. And if you take V7, V8, V9, you will have a Q wave with ST segment elevation. This is called STEMI. So you will have a horizontal ST depression in V1, V2, V3 with tall R wave. Ratio to R to S is more than 1, and there is an upright T wave, very, very significant of a true posterior wall MI. At V7, V8, V9, you will have a Q wave with ST segment elevation. So, there is always a question, is Q wave a permanent finding in ECG? In general, the development of a new Q wave indicates myocardial necrosis, which starts within few hours after acute MI. If not treated, if you don't do revascularization, or even if you do a revascularization and it fails, then you will have a permanent Q wave. That means you have got a permanent damage to the myocardium, producing a scar tissue, and scar tissue will always produce presence of Q wave. So, pathological Q wave are considered as a sign of a complete MI, and with no benefit of revascularization due to myocardial necrosis. This is a wrong belief. It must be subjected to revascularization. So pathological Q wave should not be considered as a sign of completed MI, should not prohibit from urgent revascularization, or we call as primary PCI. Also, you should suspect a person who has got a typical angina where there is a decreased amplitude of a QRS complex. Say here you can see that the person is having small q, R is becoming taller. Now say he gets an anginal pain. Now here you don't have a R wave progression in V1, V2, V3, and even if you see in a V4, there's a small R wave only. So R wave amplitude has decreased, and then later on, if you come across this is acute MI, what a person is developed. So you must keep a watch. So if any person who has got an ischemic chest pain, and if in an ECG, in a V1, V2, or we can say in an anterior chest slits, if you come across a reduced QRS amplitude, almost you are having a QS pattern, do keep it in mind, it could be acute ischemia or acute coronary syndrome. So formation of a pathological Q wave can occur after that. Do keep this thing in mind. So extensive subendocardial infarcts in a non-STEMI patient, you will have a reduced voltage. So you get this reduced voltage, reduced R wave amplitude, and slowly, because of a piecemeal necrosis, because of persistent ischemia, there will be necrosis, and there will be development of a pathological Q wave with extensive necrosis. So this could be the early finding which can end up with STEMI. So non-STEMI can end up with STEMI. So do keep this thing in mind. So piecemeal necrosis will decrease R wave amplitude. Non-STEMI is very, very high chance, and that can end up with a complete transmural infarct. So a person, when you get this finding, reduced QRS complex, may or may not be with a pathological Q wave, person should be subjected to what we call as a revascularization to prevent irreversible damage to the myocardium. So this should be kept in mind. Low voltage, person has already developed an acute MI. This should not happen. So this is a high risk sign of, and do subject them to cath lab, that is angiography and revascularization. So MI is divided into two big groups, Q wave MI and non-Q wave MI. We also use the word STEMI and non-STEMI. So you should find out the non-STEMI groups, and one of the odd presentations of a non-STEMI group is a reduction in a R wave in anterior chest slits, and later on you can have a QS pattern with STT changes. So presence of a pathological Q wave does not necessarily indicate old MI. It can be STEMI or can be also non-STEMI. Loss of normal Q wave in V5, V6 suggests left bundle branch block. Always keep that thing in mind. So if you don't have any Q wave in V5, V6 and there is a broad QRS complex, suspect left bundle branch block. Now, can they appear with patient without coronary artery disease? Answer is yes. We have already shown you lot number of cases. That is left bundle branch block, left anterior hemi block, left posterior hemi block, WPW syndrome, myocarditis, even in case of Takasubo, then chest injury, myocardial contusion, infiltrative disease, hypertrophic cardiomyopathy, dilated cardiomyopathy, etc. in all these conditions. Now, particularly in these three conditions, you have got a damage to the myocardium, but it is not because of the coronary artery disease, so it does not fall into this group. But it is a structural heart disease resulting into myocardial fibrosis, which can be lethal. So you should be able to identify this group: hypertrophic, dilated, cardiac amyloidosis, etc. And this is very, very important, because in this particular group, you will have finding in echo. Also, you will be able to find out by doing a cardiac MRI. We call short form CMR. So cardiac MRI scan will be very, very helpful. So you try to investigate properly and come to the closest differential diagnosis so that you can support them by a proper treatment. There is another group we call as the athletes. Now in an athlete's good number of time, you will have a tall QRS complex and a deep S wave. It is also described as a tall skinny Q wave. So you will have, Q wave. So it will be a tall skinny Q wave with a tall QRS complex, and person is athlete. Do suspect person is having left ventricular hypertrophy. So athlete very frequently will have left ventricular hypertrophy, which can be seen in a chest leads, quite common. So now they are coming out with a new improved specificity and new criteria, that is a ratio, and which was described in 2014 and 2017 regarding the ratio of a Q wave to the R wave, and that already we have discussed. And that ratio you should not consider in lead 3 and AVR, because in this two you can have little deep Q wave, so that should be considered. This is a asymptomatic female athlete. You can see there is a small Q wave in lead 1 AVL. In AVL there is a deep Q wave. This should be considered as normal. But being a female athlete, you have to pay attention. You have to pay attention in athletes, because they are then prone to, they can have what we call as a dilated cardiomyopathy or hypertrophic cardiomyopathy. You have to rule out those conditions in an athlete, which prevents them from doing those activities. So athlete with LVH, and these are genetic etiology in a hypertrophic cardiomyopathy. You will have to identify by doing a detailed study between the two. Here you will definitely get the genetic defects, means you will have to do a study for genetics, and here you can identify by a good history, ECG, echo, etc. Now in a case of a septal hypertrophy, particularly in case of a hypertrophic cardiomyopathy, in lead 1, lead 3 and chest leads, you will have a deep Q wave in lead 1 and lead 3. This is also described as tall skinny Q wave, which will be very, very common, almost in 20 to 20%, 10 to 20% of hypertrophic cardiomyopathy. You will be having Q wave in lead 1 and lead 3 clear cut. Also you will see a small Q wave, but thin Q wave in V5, V6. This suggests more in favor of hypertrophic cardiomyopathy, confirmed by doing a echo, which will show you asymmetrical hypertrophy of interventricular septum or asymmetrical hypertrophy of LV chamber. In case of cardiac amyloidosis, also you will have an appearance of low voltage complex with pathological Q wave. Usually in a case of amyloidosis or what we call the infiltrative disease, either in inferior wall leads or in anterior chest leads. So you can have an appearance of a pathological Q wave with low voltage complex. And whenever there is a low voltage complex with pathological and clinical history suggests non-ischemic groups, always do keep it in mind. It can be infiltrative disorders like cardiac amyloidosis, sarcoidosis, etc. And that is also given a name, pseudo-infarct pattern. There is another question. Is Q wave present in normal individual? Yes. If there is a improper lead placement, particularly if there is a exchange between right arm and left arm, always keep that thing in mind. So if there is a new Q wave appearance of QS complex as compared to prior tracing in absence of chest pain, always keep it in mind. It can be lead reversal, particularly left arm and right arm reversal. What you have to do is correct the position of lead, again repeat the ECG and get a good history of ischemic heart disease. If it is absent and by reversal of the lead, it will come back to normal. You can see here, this is non-pathological Q wave. You have got inverted in lead 1 AVL, and in AVR you have got upright. This is between right arm and left arm reversal. So whenever you get a reversal in right arm and left arm, just again reverse back the lead and take the ECG again. It will be normal. Here you can see that in lead 2, lead 3 and AVF there is QS pattern and AVR is upright. So this thing can also happen because of lead reversal. So do keep it in mind in a lead reversal, because here the person will not have any history of chest pain. So always keep it in mind, in absence of chest pain, if you get a QS pattern in a limb leads, it is a reversal of limb leads. And occasionally you can come across lead reversal in chest leads. Again you can see here, lead 2, lead 3 and AVF, there is a QS pattern while AVR is upright. Always think of lead reversal. There is another condition which can also have a Q wave in a pre-excitation syndrome, we call WPW syndrome. Here you can see this is a QS pattern. This is a delta wave. This is a clear cut, you can see in lead 1 AVL, V4, V5, V6 short PR with a delta wave, straightforward in case of WPW syndrome. But in an inferior lead you can have a QS pattern, and you might see sometime QS pattern in V1, V2. So always keep it in mind. Same, you can see in lead 2, lead 3 and AVF QS pattern, but there is a short PR with delta wave. This is again WPW syndrome. You can sometime that particular changes may disappear. Here you can see that this changes has disappeared, same person. So that is described as an intermittent WPW syndrome. So if a person develops tachycardia, that particular sign may disappear, and again as soon as the rate comes back towards bradycardia, you will have an appearance of this inverted with Another leads, that is lead 1, AVL, V4, V5, V6, will have a short PR interval with a delta wave. Occasionally, you come across the delta wave may not be seen, but you will be seeing a deep Q wave. This is again a significant in case of a WPW syndrome. This is with 25 speed, this is with 50 speed. So it will be persistent. Now presence of pathological Q wave in several leads or in a lead group or specific vascular territory always in favor of MI. If there is a Q wave which is pathological, means depth wise and duration wise and ratio wise, and there is an associated ST segment changes, ST and T wave changes, 100% in favor of MI. This is that criteria we have already discussed before. There is one another condition where person may not have a chest pain. We call it a silent MI, or we also call as unrecognized MI. Now, if by chance we come across this, always first rule out lead reversal. If lead are properly placed and still there is a persistence of pathological Q wave with ST segment changes, always suspect this is silent MI. And if this is also seen in a previous ECG, this will be considered as silent old MI. And you can confirm at present acute MI, but of a silent variety, by other way of investigation, that is echo, which will show you abnormal myocardial motion, thickening or thinning of the region, and that will be or even troponin being elevated. And finally you can confirm by doing angiography. So that will give you an answer. So always keep this thing also in mind. You can have a person without any chest pain and can have a pathological Q wave due to acute MI. We call it a silent MI or unrecognized MI. And this is very common in old age, person with diabetes mellitus, and also in the person who has undergone cardiac transplant. So criteria for prior or silent MI or unrecognized MI is pathological Q wave with or without symptoms in absence of non-ischemic causes. You do a cardiac imagination, there is a loss of viable myocardium, and there is a pathological finding of a prior MI. All this will tell you that there is a prior MI, or we call old MI or silent MI or unrecognized MI. So we come across two groups. One we call STEMI and another we call is a non-STEMI. So always this is difficult to identify, but still we should keep it in mind. Person can come to you with a persistent chest pain with pathological Q wave and there is no elevation of ST segment. Do keep it in mind, it can happen in a non-STEMI. But in a STEMI, you will have a pathological Q wave with ST segment elevation and T wave changes. It is little bit more easy to identify. But in presence of a chest pain and there is no ST segment elevation, you should keep it in mind. A Q wave may appear because the non-STEMI is now becoming STEMI. So I end my lecture here. I hope this will be very, very helpful to you, because good number of time a small Q wave somewhere in the ECG, we suspect this is an old MI. Look for all those classical criteria. We have already mentioned those criteria for old MI, acute MI, pathological Q wave but non-ischemic like left bundle branch block, LAHB, LPHB, WPW syndrome, hypertrophic cardiomyopathy, dilated cardiomyopathy, all those groups which we consider as non-ischemic condition where you can have a pathological Q wave, all those should be kept in mind. But you should be also able to differentiate a pathological Q wave in person with the old MI and acute MI or healing MI. This should be And also you should be able to pick up non-STEMI and STEMI. If you like this lecture, please press button like. You can subscribe and you can also share this with your friends whom you find it will be useful. So thank you again for taking out time. I know that your time is very valuable and I appreciate you for spending some of the time with me. So I end my lecture here. See you in the next lecture.